And number 2, please make certain to use your participant code. If you have joined and not used your participant code, you are able to go ahead and type in the hashtag sign, that participation code, and then hashtag sign again. That will go ahead and connect you with audio so that we are able to mute and unmute you. And we can go to that next slide. Thank you. And then we do want this call to be interactive, even with a group meeting the lines. Please do use the chat box to type in questions and comments. We want to hear from you, hear and learn what's going on at your sites. Additionally, you can come off of mute, as you heard from Rachel Staley, our project specialist, by pressing *6 to mute or unmute. We can go to the next slide. For those of you that aren't aware, OPQC currently has an active QI initiative with a number of sites across the state with an aim to improve care for the pregnant patient with OUD and her infant. It's called Moms Plus. The plus is plus the infant to include that baby with the maternal infant dyad. Some of our Moms Plus faculty today will be presenting on this call. We have Dr. David McKenna from Miami Valley Hospital, Dr. Mona Prasad from Ohio Health Grant Medical Center, Dr. Jennifer Baylett from Metro Health Medical Center, and Dr. Mike Marcotte from Tri-Health Good Samaritan Hospital. We can go to the next slide. Keeping with the foundation of a collaborative, I want to go ahead and just share some goals for today's call. We're hoping to share practicalities of implementing strategies now. I think that the sharing from our mentor sites here with our project and those on the call, we want to learn what is going on, and we want to discuss what people are doing where guidance doesn't exist. We're all in this new situation and looking for guidance, and hopeful that we will have, that will be one of the outcomes of today's call, really an all teach, all learn approach. We did have over 230 registrants to this call, and there were several submitted questions on registration. Taking those into account, we prioritized topics and scenarios to, number 1, this vulnerability of the patient population, the pregnant mom with OUD, with this COVID pandemic, and then alterations to care specific to the pregnant patient with OUD. Some caveats here: we will provide resource links on our website. They are updated regularly. We also will have the slide deck and the recording posted on our website, and we'll lastly have a follow-up survey. We want your feedback in order to improve. And lastly, the case scenarios are from individual institution responses. They are not necessarily OPQC recommendations. I do want to throw that out there. All right, we can go to the next slide, please. This slide was constructed to show the global, national, and state data related to COVID. We update it daily. This is as of yesterday in the state of Ohio. Our medical director of ODH, our director at the Ohio Department of Health, Dr. Amy Acton, has an update every day at 2 p.m. So our data is indicative of yesterday. You can see there are over 1,300,000 cases worldwide with over 72,000 deaths. And nationally, we have, as of yesterday, 330,891 cases. And in Ohio, we have 4,450 cases, with 371 of those being ICU admissions and 1,214 hospitalizations in Ohio. We have had 142 deaths across the state to date. Dr. Jennifer Baylett, who is on the call as well, has shared some modeling data as well. Dr. Baylett, did you want to go ahead and share some of that as well?
Sure. So there are 3 main models that people are working with: the University of Washington, the Ohio State University model, and the Cleveland Clinic model. Most interestingly, the University of Washington model, which is really geared towards healthcare utilization and planning for healthcare providers, updated their model yesterday to say that we will be peaking tomorrow in terms of healthcare utilization and in 8 days in terms of deaths here in Ohio. Other models put us out differently. The OSU model predicts that we will be at our peak around the 25th or so of this month. And the CCF model, last I heard, was predicting that we were going to peak around May 1st. So we shall see. I'm personally keeping my fingers crossed for the WashU model, I'm sorry, the University of Washington model, as that would have us at peak tomorrow with enough ICU beds and enough hospital beds predicted. So fingers crossed, we shall see where this goes. Thanks, Susan.
Thank you, Dr. Baylett. Encouraging news that we'll continue to keep our eye on. All right, let's go to the next slide. And we want to take a quick poll here and realize that we have, this is not looking at just the state of Ohio, this is everybody that is on today's webinar. How many of your pregnant patients with OUD have been diagnosed with COVID-19? You can see the responses below, and perhaps it's I don't know or not applicable, which is fine also to answer. So if you'll go ahead and submit your answers into the poll. Again, we want to know how many, the number of pregnant patients with OUD have been diagnosed with COVID-19. And our project specialist, Tracy Flynn, is running our poll. And Tracy, I'll rely on you to let us know when you're going to close it out. All right, it looks like we have 29% have 0, and then after that we have 13% of 1 to 5. It doesn't look like anyone has greater than 5 patients that have tested positive, and the largest submission is that people are uncertain. All right, helpful information. Let's go to the next slide. All right, it's my pleasure now to turn the call over to Dr. Dave McKenna and Trish McVeigh, his nurse navigator at the Promise to Hope program at Miami Valley Hospital. So Dave, I'll turn it to you and Trish.
Thank you. Can you hear me okay?
Yes, loud and clear. Thank you.
All right, I got the unmute down. So big shout out to UW. I hope they're correct. So I'm Dave McKenna. I'm one of the maternal fetal medicine specialists at Miami Valley Hospital. We have a program here for women who are pregnant with substance abuse disorder. It's called Promise to Hope. And today I was just going to talk a little bit about some of the things that we need to keep in mind to maintain good quality care for our patients with substance use disorder. There's no evidence to suggest women with SUD are going to be at increased susceptibility to infection from coronavirus or to more severe disease any more than any other pregnant patient. However, the uniqueness of their underlying medical condition requires some additional considerations during this time of stress. And at any time, a person with SUD is going to be at increased risk for relapse when they're stressed and they're anxious, and their support system may not be intact. This is further exacerbated during this time because a lot of the wraparound services that we provide, such as the social services, housing, food, transportation, and even the outpatient MAT providers may not be considered essential services and may be closed or cutting back. And in Ohio, of course, we have the stay-at-home order, and this may be further stressing our patients if they're in an unstable home environment or also in a group home. And then one of the things that is being encouraged is to get outside, maintaining appropriate social distancing. However, that really may not be possible in a neighborhood that's not entirely safe. And a lot of our patients don't have good personal support systems, and it's making all of this much more difficult on their road to recovery. And we just want to make sure that they don't relapse. And of course, all of this is dependent on where they are in their road to sobriety. So what I thought we would do is Trish McVeigh is going to give us a case presentation of a patient that we have currently in our program who has had some difficulty with the current situation. Trish?
Hi. The patient I'm presenting is 27 years old. She's a gravida 5 para 4, 32 weeks. She began her sobriety treatment presenting to the hospital in January, middle January at 19 weeks for a Subutex induction. She had a history of IV heroin and amphetamine use for 4 years.
Could you go to the next slide, please?
Okay. She desired to have residential treatment, and once her induction was completed, we were able to do a bed-to-bed transfer with a residential treatment provider and provided for her a bridge prescription. She remained there for a few weeks and then left. Soon thereafter, she relapsed. The end of February, she reconnected to one of the Promise to Hope providers, outpatient providers for MAT services. And they referred her to Promise to Hope to obtain prenatal care. The beginning of March, I met with her and got her connected to prenatal care and got the consent signed. And she was seen in our clinic on March the 12th and was scheduled, she was seen for her nurse intake and then was scheduled for an OB appointment on March the 26th, which she did not make. During our weekly report on March the 30th, our partner informed me that the patient did not come in the previous week, and she wanted to know if she had made her OB appointment, and I informed her that she hadn't. And then I reached out to the patient and left a voicemail to reschedule her appointment. On 4/2, she called stating that she was sick last week and thought maybe she had a virus and had missed her appointment with her provider, and as a result was out of medicine, and now she was feeling sick. And it was unclear whether to her if it was a virus, but she knew that she was in withdrawal. So I advised her to call her provider and then to call me back. And of course, this is at the end of the day. And in the interim, I contacted our medical director, Dr. Kroom, and made him aware of the situation. And he was agreeable to write her a couple of days bridge prescription, and if her provider was not able to see her that day. The patient called me back, and sure enough, they weren't able to see her because she had made no contact with them. And because of the situation, we really wanted to minimize her exposure and not bring her to the hospital. So we provided a bridge prescription, and then she was seen by her provider after a couple of days. And I think the key points that I just wanted to point out that the communication between the outpatient provider and Promise to Hope was key in this, because otherwise I wouldn't have known she didn't make their appointment, and they wouldn't have known she didn't make ours. And I think the other part is the changes in practice of what we've had to do in light of the COVID-19 to try to minimize exposures. A lot of the outpatient providers have canceled their groups. And so my concern for the moms are, what are they doing for their social aspect? And the other piece is making sure that there's education for the moms on what to do if you're sick or missing appointments. And for me, it's having them to contact me as well as a resource to see what I can do to assist.
Excellent. Thanks so much, Tricia. I appreciate that. I think, you know, the one thing that that I really gleaned from this, that this was definitely a near miss, in that this patient was withdrawing, and if we hadn't bridged her at that point, she would have relapsed. And I think that that really is important, that we don't miss patients like that.
And the other thing I forgot to mention was that I did do kind of like an assessment over the phone to kind of assess her symptoms.
Right. Yeah. Excellent. All right.
Thank you so much, Dave and Trish. Very helpful. I think it's important, like you said, to point out that, again, needing to speak with the parent, speak with the mom, and learn more about her symptoms to decide, is this withdrawal or is this perhaps viral related? You can feel free to type in questions and comments into the chat box for Dr. McKenna and for Trish, and we're going to move on. Trish did talk about the need for assessing over the phone and having an element of telehealth there, and Dr. Mona Prasad from Ohio Health Grant Medical Center is going to go ahead and talk a bit more about that. Dr. Prasad?
Great. Thanks, you guys. My name is Mona Prasad, and I'm, like Susan said, practicing currently in MFM and addiction medicine at Ohio Health here in Columbus. To put things into context of what I'm going to suggest, I think it's helpful just to remind folks that ours is a co-located program. So our general model of care is to see patients in the same space weekly for a group therapy visit. They get a urine drug screen, they receive a prescription for MAT, and then they receive prenatal care in as at the relatively the same cadence as a normal prenatal care process, though we may tend toward every 2-week visits a little bit earlier in pregnancy than standard. So I think what makes this time around OUD so interesting and difficult is that we're used to the provision of this type of care with lots of rules and check marks to ensure that we're practicing in this field of medicine in the most rigorous, evidence-based way, and really challenging ourselves all the time about doing no harm to patients. I think where we land in the setting of a pandemic is that it truly asks us what is essential. And I think that notion and trying to adhere to that just takes us to a place of discomfort. And we're kind of out there feeling a little bit unsupported and on a limb. I think it's helpful to understand, remind ourselves that the tenets of MAT in pregnancy are for harm reduction. And we're just extrapolating that into this pandemic to what is essential in still provision of that harm reduction model. And I think what is essential is to make sure patients get MAT and avoid relapse, try to keep them linked to counseling and behavioral health, and to get appropriate prenatal care. So I think with regard to MAT, we've adopted various strategies to make that a little bit more accessible without patients actually having to touch the hospital or our office clinics to get a prescription. And so for some, we have been writing scripts to last until their next prenatal visit. So we have adopted a prenatal schedule in our clinic that matches up to kind of a modified obstetric schedule. And so we have either been giving them enough to last till that next visit, calling in prescriptions for patients if they can't make it in, or if they have fear that keeps them in their place. Or if we're concerned about misuse or putting too much medication in a person's hand at one time, doing prescriptions with refills, and then really challenging ourselves to get comfortable with continuing treatment without that reflexive urine drug screen to corroborate those visits. I think the interesting thing is if we are getting better and better at open-ended questions, if you feel like you need to document something, I think a very easy open-ended question to apply is, what would your urine screen be positive for today? And you can add that to an e-visit or a telephone note if you have that capability. And we'll talk a little bit more about capabilities for telehealth in a second here. But I do think it's a time where we have to have a little bit of faith and a little bit of trust in the process, and just know that in the grand scheme of things, our goal is for harm reduction. So we have spaced out our in-person OB visits in conjunction with recently modified guidelines for care. But if patients need routine surveillance for fetal concerns and whatnot. We have not changed that. And then I think getting back to what is essential about this, I think it's essential, but not necessarily essentially patient facing for patients to remain in contact with groups and individual counseling. So one thing that I have employed with patients that had transportation issues or whatnot outside of this pandemic was the ability to engage in online meetings for group visits like aa.org. So there's definitely access to online AA meetings. So I think that has a place here, particularly in patients that may be newer to sobriety and might stabilize them. So I think, and then of course we have to kind of engage in our ability to do video and telehealth visits. So I think we'll take the next slide. So at Ohio Health right now, and I think we'll be specific about just saying that this is not everybody's system, and I think we have to be really close as we're rolling out remote visits in our local communities to follow the guidelines of your establishments. But as a I'm watching a webinar at the same time. Just as an example, at Ohio Health we have Epic, which has kind of allowed us to push fast forward on current operations toward optimizing virtual visits. There is both the opportunity to do telehealth, which is just a phone call to a patient, as well as video visits through the MyChart ability in Epic that we're rolling out slowly but surely. Some practical aspects that come with the use of remote visits are this need for video visits requiring consent and telehealth visits requiring consent. And in practice, I've just offered up the Ohio Health sample consent that just says, I discuss the risk, benefits, and alternatives to telemedicine with the patient and any accompanying persons, including the risks that the patient's personal health details and medical records will be discussed in this way, may be recorded, and there are inherent limitations compared to a face-to-face evaluation. I think it's also, we've employed the need to document where you are as a provider and to document that the patient is indeed at home, which might invite some differences in terms of what is home defined by, but the spirit of it, and I truly think the intent is just to document where that person is, even if it's not home, if it's a shelter, if it's a group home, if it's a, I'm in their car or whatnot, just so that it is documented. That's part of it. And then we have been able to just do billing, same as you would for any E&M visit, but with this GT modifier that is part of the billing process. I said earlier, I'm grateful that this doesn't seem to be the hugest priority, this billing component, but there is, this modifier at least allows for the potential for that billing. And again, I think this is just an example of work that's done at Ohio Health. It's not necessarily best practice. I think it's an improving practice, and I think the best thing to do is just to focus on where what your systems allow. I think right now it's obviously difficult to be providing OUD care when you can't see people and you can't have that accountability as part of it. But I think the thing that sort of keeps me on pace is that I learned in surgical training that the enemy of good is perfect, and that might be a good mantra to keep us on point in the provision of this care.
Thank you, Mona. That was wonderful, very helpful. I'm wondering if any of the attendees have had the opportunity to do some either telephonic or virtual e-medicine, like a video with their patients, and if so, if they've had the opportunity to ask them the question, like Dr. Prasad posed, what would your urine screen look like today? I'm also wondering if anybody has had success or feedback with the online meetings for either AA or NA. I know that has been pretty big out there. There's lots of support on their website, and again, wondering if there's any feedback pertinent to that. Mona, you mentioned that the patient has to be home, and I'm wondering if you could speak a bit just about what that might look like in the face of where Dr. McKenna had talked about some domestic issues. Is home safe? Is the area safe? Is that anything that in doing this telehealth that you're able to speak on?
Oh, I think it can be a barrier for sure if people don't have a safe space to connect and to feel comfortable in providing that care. So it can certainly, I think, represent just one more barrier to this population of people that struggle with resources in general. So I think the notion of home comes more from a billing and coding imposition on the documentation rather than truly assessing for it as a safe space or as a place that they can actually call from. But I think your point is well taken. And just because I'm talking, it's a little bit off topic, but we have had patients who really have needed to be hospitalized recently with OUD, with growth restricted babies, or one that has preeclampsia and twins, and they refuse to come to the hospital because of our current visitation purposes. And so we've got people floating around out there, and right now limited abilities to connect with them even remotely.
Thank you. Yes, I agree. Some challenges that we need to overcome. Well, thank you very much. I'd like to go ahead and transition to the next slide, and we can go ahead and hear from Dr. Baylett at Metro Health. Please feel free to go ahead and type in your questions and comments, your shared experience here, as we all teach, all learn here. Jennifer, I'll turn it over to you.
Hello. So one of the questions I've been getting from my staff is, are the pregnant patients with OUD at higher risk for COVID-19? And I'll be honest, there is really no good data. This is all theoretical. There have been some concerns with patients who are actively using about whether they're truly able to social distance due to needle sharing, the needing to buy drugs, and the prostitution that we all know goes along so often with active use of opiates. For the moms on MAT, there's been concern about the need to go to their clinics to dose. Obviously, that's not true for everybody, but for women on methadone and some of the Subutex OTPs. And then the concern is with the group homes. So I'm finding that we have a little bit of staff bias, that the staff are assuming these women can't social distance. Again, no good data. But one of the things that has been real is trying to quell the fears of the staff about taking care of women with OUD. And let me just add that these are staff members who typically care for women with OUD all the time, happily, joyfully, enthusiastically, but the COVID has made them a little bit scared. So we've had to do some reaching out and education to our staff members. Next slide, please. So let me review a case that we've had recently, which I think brings up some interesting points. We had a 26-year-old gravida 2 para 0010 at 26 weeks, called the doctor with symptoms concerning for COVID-19. She was stable. She was told to self-isolate. She didn't need to come into the doctor or the hospital at this time, and appropriate precautions were given. She reports that she lives in a group home and that she has a bedroom to herself. However, she was still going to group therapy and eating in a communal setting. She did not want to tell the management of her symptoms because she feared being dismissed from the group setting. She's not going to be COVID tested and is a presumed COVID positive. So then I, as a provider, was left with sort of the dilemma of needing to respect the patient's HIPAA, and at the same time, potentially having a public health crisis at one of our group homes in the area. So rightly or wrongly, this is what I did, and I'd be curious to know what others think of my actions. I called the director of the group home, And I said, I can't tell you who it is. It's a large institution. I said, I can't tell you who, but I can tell you that you have somebody in your home who has symptoms concerning for COVID. I think you need to go through, and rather than just asking people to self-report to you, you maybe need to ask people how they're feeling, think about what you're going to do in terms of eating for somebody who is positive or got symptoms, regardless of whether it's COVID, in terms of delivering food to their rooms, and how are you going to handle group therapy sessions? Can that be done electronically from their room somehow, or what are your options? And the director thanked me for my heads up that she had an issue, and was going to proceed to make some changes in how they were doing their programs. So at that, I'll drop off and leave it to others to comment.
Thank you, Dr. Baylett. I think you bring up a great point of just the environment, and where the group home, like you said, is really, I'm sure, challenged to provide appropriate social distancing. I think you had mentioned also that are they still utilizing the same approach with food? Were they able to have the dining situation where they were able to alter that at all?
Yes, they went through and they were going to, I believe they were going to deliver meals to the bedrooms of folks who needed to be isolated a little longer. I did not get an answer from her about what they were going to do with the group therapy piece, whether they just wouldn't go for that time being while they were sick, or whether they would have an electronic solution.
Right, right. We do have a question in the chat box. Was adult social services contacted to work with you to come up with a solution?
So ironically, they had contacted me about the situation. So I didn't call them back to deal with it. My social worker had been in touch with a patient, and as just part of her routine touch base, and realized she had symptoms and referred her to me for management. I did talk to the social work team about their thoughts, and they suggested we call the director of the home. So they were an integral part of the decision making, but it's not an outside referral. They're my team, the social workers.
It's helpful guidance, Jen, that also points to the importance of just this shared decision making amongst a multidisciplinary team, and the importance of such. All right, any other questions for Dr. Baylett? You're able to put them in the chat box. Feel free also to raise your hand, and our project management team will be able to unmute you. I see that we did get a question in the chat box pertaining to providers dealing with logistical barriers, with clients not having phones or having limited data. And I see that Dr. Prasad has answered that as well, just the concerns being spot on, and that we're, again, with the harm reduction, doing the best we can with what we have, and not ideal for this resource poor population. Dr. Prasad, any feedback as well with social services or social work in the ability to mitigate that?
Sorry, I was on mute there. You know, I actually welcome the input. I think it's something that we can tap into to try to help. I think our group right now is relatively small, and I think the people do have access, the ones that we've tried. Obviously, that's critical to making sure that this is even an appropriate intervention, is making sure on the front end that this is accessible technology to patients. But I think in terms of trying to spread such an intervention, that you have to make sure that that's accessible, and trying to take those barriers down. I mean, with any hope, we'll be back to quote unquote normal soon, but I think it's a point that needs to be taken.
Thank you, Mona. All right, I do see another question pertinent to visitation for antepartum and for NICU patients. And I think that our next slide and our next presenter is going to cover that. Although I see one more question. I apologize, Chloe, could you go back one slide? And Dr. Baylett, there's a question in the chat box that would be pertinent to you. The question is, who would have case management jurisdiction in this case?
So we don't really think about it in terms of case jurisdiction so much as collaboration. My team does case management for the patients who get prenatal care at Metro Health with OUD. Obviously, they have case managers from the insurance companies. They have a caseworker at the group home. They have a sometimes probation officer who's involved. So there's lots of people involved. In terms of the group home and what the processes are there, the director of the home actually has the impetus to be able to make changes in the program. So I'll leave it at that.
Thank you. Thanks. And I see that Pat Heinrich from NICHQ has typed in also the CDC recommendations for long-term care facilities also, which can be helpful to a group home similar to this in our chat box. All right, thank you. Let's go ahead and move forward to the next slide now. And I will go ahead and turn the call over to Dr. Mike Marcotte. And again, we have received some questions regarding visitation, and I think that our last presentation here will definitely address that. So again, feel free during Dr. Marcotte's presentation to type in questions and comments into the chat box that we will address. Go ahead, Mike.
Thanks, Susan. Can you hear me?
Yes, thank you.
Okay, so my presentation is going to follow up on Dr. Balitz's around talking about what is actually happening in a residential treatment program. I am the medical director for the HOPE program at Good Samaritan Hospital in Cincinnati, and I practice maternal fetal medicine and addiction medicine. And probably about 6 years ago, I became the medical director for a program called First Step Home in the community, which is a residential program that accepts pregnant women and children and other women who have a substance use disorder. We have about 100 women that live on campus with us with their children. And so as you may guess, this pandemic has really stimulated a lot of concerns and discussion. It was very coincidental. The week before this all really broke in the United States, we had an infection prevention team come to our community just to talk to us about how to help reduce the chances that we would spread both viral infections and GI infections, because we every year seem to have periods of time when many of our children are sick and the women get sick. And just to follow up on all the other discussions from my colleagues, we definitely see a lot more upper respiratory infections in our adult population. And many of our children have recurrent viral, gastrointestinal, and respiratory symptoms. And it's very challenging in these communities to help reduce the chances of those kind of infections spreading around the community. So we're very concerned as we're entering this pandemic that, you know, the women in our program are going to pass this around quickly, and it was going to incapacitate many of them and increase their chances of hospitalization and severe complications and even death. I'm glad to report as of today, we don't have any positive tests, but we have had several infants readmitted to the hospital for respiratory infections, and several women who have had upper respiratory infections, but none of them have tested positive of the ones who have been tested. But what I thought I would start with is just to review some of the issues that have come up for us. And I think, in a lot of ways, it's kind of a summary of many of the presentations today. I think we've recognized that in residential treatment, many times when there are situations where we're reducing direct contact with patients for prenatal care and for pediatric care, we're having to have increased responsibility in our medical team at the residential treatment program for the overall care of those patients. Emergency rules have been put in place within our residential program to try to reduce the possible exposure to COVID-19, such as we've stopped having visitors be allowed to come, which significantly affects our new moms who have safety plans where they have out-of-home placement of their infants and would normally be able to visit with them, but can't in this time. We've stopped having women be able to leave to go on passes, even though they are progressing through our program and would normally be able to leave on the weekends to visit family and friends. That has created a lot of strain for our population, both in terms of their fears of getting the infection, of their children getting infections, and because of the increased movement restrictions. So I think the key point all throughout our conversations today emphasize the importance of us increasing our communication with partners. The other thing that you may or may not know is that smoking increases the incidence of pneumonia in patients who develop COVID-19. There is a receptor in the lungs that is promoted by the chemicals in a cigarette smoke and increase the receptor content, therefore allowing for the coronavirus to bind more rapidly to the pulmonary circulation. So just another reason for people to stop smoking when they're in treatment. We've also had quite a bit of procedures put in place to help us to know what to do when someone develops signs and symptoms in a residential setting. And we typically will take them off of going to groups. We put them in a room by themselves. If they have their child with them, the child stays with them. If the child is sick, we have the mom stay with the child. And that, you know, often is very disruptive in a community and financially can affect income for the residential program because they bill for those visits. And this week, our newest thing is trying to develop a process for all of the women to wear the cloth masks all the time out in public, as is recommended by the CDC, and for our teams to be prepared if we do have a mom who is positive, where we're going to put them, how we're going to keep them. And then lastly, one of our main treatment providers is a methadone clinic, and they have made modifications to allow for increased take-home meds for our moms since they're in residential treatment, which has increased our burden in our med room because now we have women who would normally go to the methadone clinic every day coming to the med room to receive their methadone. Next slide. So I wanted to review a case that we had. This mom actually had just recently left residential treatment and moved into her own apartment. But she called me a couple weeks ago and was complaining of a respiratory infection. Her son had recently been sick, and I felt that she had enough of the symptoms, including shortness of breath, to advise her to go to the assessment center at our hospital to be assessed for COVID-19. And her assessment landed her in the ICU. And because she was 37 weeks gestation, we made a decision to induce her labor. And she did deliver vaginally in the ICU. Her respiratory symptoms did not worsen. She did not require intubation, which, as you may be aware, patients who are being admitted to the ICU have a very high rate of intubation. And so that was good. But there were many issues that came up with how to manage her dyad care after the delivery. She was kept in the ICU until postpartum day number 1. And luckily, we were able to get a relatively rapid turnaround for the COVID-19 testing, which did return negative. But she did have all the signs and symptoms, so there were many of us who were questioning whether this was a false negative, which can occur up to 20% of the time. Her baby was immediately separated from her at delivery and moved to a room with one-on-one nursing. She was not allowed to see the baby initially. She did initiate breast pumping, and most significantly, she had no one to come to the hospital to be with her newborn. She ended up calling the father of the baby, who had recently been released from prison, and he was not in treatment and was not able to really stay with the baby because of many problems with that. On day of life 2, the concern was that the baby's Finnegan scores were increasing. She had been on methadone and in treatment for about 4 months before delivery. But the concerns were, could we initiate some of the non-pharmacologic bundles to prevent the baby from needing to go on methadone? How could we work as a team to develop a strategy that would allow her to be the primary caregiver for the baby? What kind of implicit biases arose as we were developing plans for newborn care in this situation? And how could we develop customized treatment plans that would allow the patient and her baby to optimize their outcomes? And then what kind of additional threats occur when a mom is in recovery but not able to care directly for her infant because of concerns for exposing this newborn baby to the COVID-19 virus? So I'll stop there. I do see a question in the chat box about methadone or morphine. And again, neonatal management of neonatal abstinence syndrome is customized based on the site. And we know that there are certain sites that continue to use methadone, and one of our, and that is true at Good Sam and in most of the neonatal ICUs in the Cincinnati area. So thank you, and I'll be happy to answer any questions.
Yes, thank you. Thank you, Dr. Marcotte. And to just build on your reply regarding the question of NAS treatment with methadone versus morphine, OPQC worked from, I want to say, 2014 to 2018 on a QI initiative with the special care nurseries and the neonatal intensive cares across the state. And that information is on our website as well. Deborah, it's the, like Dr. Marcotte said, it is the choice of the hospital whether or not to use methadone or morphine for treatment of NAS symptoms that you're not able to, that are escalated after non-pharmacological care has been instituted, and those Finnegan scores continue to rise. And like he said, there are pockets of the state that do have methadone, some morphine. I know in Northwest Ohio they use methadone, and it seems in Central Ohio and Northeast Ohio morphine is utilized more frequently. So you are able to find that guidance and that protocol on the OPQC website. We do have some questions about visitation, and I think, Dr. Marcotte, you bring up a very valid point here about the challenges of trying to keep the staff safe, trying to keep the unit safe, and also promoting bonding and that maternal infant dyad, where often when a baby is being treated for NAS, there's a tremendous amount of guilt and shame from the mom. I know we have a number of our NAS teams on this call. Dr. Maura Crowley is the co-director of the Rainbow Babies and Children's Neonatal Intensive Care Unit, and I know I've been corresponding with her as well as to how they are responding to this COVID pandemic and what they're allowing in their NICU visitation. Can we take Dr. Crowley off of mute and so she's able to share what they're doing at Rainbow? And please, again, feel free to type into the chat box what's going on at your institution and how you're able to work with the moms and the families with shared decision making on this at your site.
Hey, can you hear me?
I can, thank you.
Okay, perfect. So this is sort of an ever-changing or can be changing landscape and visitation in the hospital and the NICU. So for hospital-wide, for the Children's Hospital, it's not COVID related, but we are only allowing 2 visitors for the patient for their whole hospital stay, in the same 2 visitors. And then at night, only one of those visitors can room in. And all of our visitors are getting screened upon entry for any signs or symptoms of COVID, cold symptoms, travel history, and temperatures. And then those parents that room in are also getting screened every day by the nursing staff for any of those symptoms. And if those caregivers or parents or visitors screen positive, they will not be allowed to visit. And on labor and delivery, so if we have a COVID positive mom and the baby comes to the NICU, the mom will not be able to visit the baby. And we are working with our infection control colleagues to figure out, when can that mom then come to visit the baby, because especially with a preemie, they're apt to be here longer than perhaps the mom is shedding virus. In terms of who can come and visit in that case, so if the mother is positive, her husband will automatically be quarantined, so then he would not be able to visit, but she could assign another healthy caretaker to come and visit. If the mom, when she comes into delivery, is a patient under investigation, then while her test is pending and she has, her husband or the father of the baby is with her on labor and delivery, if the baby delivers before we have that test result back, he's allowed to come to the NICU. However, he cannot travel back and forth between the mom and the baby. So we have that conversation of, who do you want to stay with? And then if mom does come back COVID positive before the baby is born, then the dad actually has to stay in the room with the mother. So it's really hard, and it's difficult to, potentially having a baby without their parents to be able to be with them. And this is ever changing, and we're, working on this, and especially with our NAS population, this could be a challenge.
Thank you, Dr. Crowley. That's very helpful, and so agree, especially with this this population, as we heard from Dr. Prasad, Dr. McKenna, Dr. Bailett, Dr. Marcotte. The challenges are unique. I think that also utilizing that non-pharmacological bundle whenever possible is also good. Can you speak just for a quick minute about kangaroo care, though? I know we did have some breastfeeding guidance on last week's OPQC webinar. That slide deck and recording are on our website. But again, in light of this, how that is altering kangaroo care and breastfeeding in the NICU.
So in the NICU, so we will allow a COVID positive mom to provide breast milk with masking, hand hygiene, meticulous care of her breast pump, and kind of we have a protocol for how that milk then gets delivered to us. But we have not allowed kangaroo care, and especially since if the mom is COVID positive, she wouldn't be allowed to visit in the NICU until we have cleared her from an infection standpoint. So yeah, I mean, it will affect our babies, unfortunately.
Thank you. Thank you for that guidance and your feedback. And I'm sure, much like the other presenters have stated, that this is dynamic, it's changing daily, sometimes even more rapidly. And and challenging. We do have a question for you, Dr. Crowley. Have you discontinued kangaroo care for all patients or those that are COVID positive?
Oh, no, just for the COVID positive. So, and if, because if any of our parents who are visiting screen positive, then they wouldn't actually be able to visit. So, so if the parent is at the bedside, it's presumed that they have screened negative and they are not having symptoms. So we'll do allow kangaroo care for that.
Thank you. Thank you for clarifying. All right. Well, thank you very much. That was very helpful. Great discussion there. Again, this will be posted to our website with the recording and the slides. Let's go to the next slide, please. As our project management has been chatting into the chat box, we do have a number of resources that are online for assistance and guidance. I think that probably everyone on this call has had some sort of interaction and have probably checked out some of these sites. Again, I think that the 42 CFR guidance and the HIPAA guidelines Dr. Prasad touched on when she was talking about the telehealth. And again, I think the harm reduction is also at play here as well. On the next slide, I'd like to invite you all to our weekly webinar that we're having in response to the COVID pandemic. And this week we are going to focus on surge planning specific for perinatal units. We're elated that Ryan Everett from the Ohio Hospital Association, Dr. Jim Greenberg from Cradle Cincinnati and the Perinatal Institute at Cincinnati Children's Hospital, and Kay Smith from ProMedica Toledo are going to share with us the surge planning that they are all involved with throughout the state. And we can go to the next slide. That we will have that link to register for the webinar on our website. You're also able to access the information and the resources that were not only highlighted today, but on past webinars. And do feel free to contact us with any questions at info@opqc.net. We can go to the next slide. Again, thank you so much for your time and attention today. I know you're very busy and appreciate the ability to learn from everybody and work with everyone on this. And we can go to the next slide. Again, thank you so much and best wishes. Stay safe. Take care. Goodbye.